Your last blood test came back normal. Your doctor said you're fine. Your fasting glucose was 95, well within the reference range of 70 to 100. Your hemoglobin A1C was 5.4, textbook normal, below the 5.7 threshold for prediabetes. You walked out of that office believing you were healthy. You are not. Because if your doctor had measured one thing they didn't test, one number that costs $15 and is available at every commercial laboratory in the country, they would have seen what's hiding underneath that normal glucose reading. They would have seen an insulin level of 18 or 22 or 30, 3 to 5 times what it should be. They would have seen a pancreas that is working desperately, dangerously hard to keep your blood sugar in the normal range. A pancreas that is producing massive quantities of insulin to compensate for cells that are no longer listening to its signal. They would have seen insulin resistance, the condition that precedes every case of type 2 diabetes by 10 to 15 years. The condition that is already damaging your blood vessels, your liver, your kidneys, and your brain, while your glucose number says normal. Your A1C is the check engine light. By the time it turns on, the engine is already damaged. Let me explain why standard blood tests miss the disease that is building inside you. Because this is not a minor oversight. It is a systemic failure of diagnostic strategy that affects 88 million Americans. The standard metabolic panel that your doctor orders during an annual physical measures fasting glucose, the concentration of glucose in your blood after an overnight fast. If it's below 100, you're normal. Between 100 and 125, you're prediabetic. Above 126, you're diabetic. This test has one critical flaw. It only measures the smoke. It doesn't measure the fire. Here is the biology. When you eat carbohydrates, your blood glucose rises. Your pancreatic beta cells detect the rise and release insulin, the hormone that signals cells throughout the body to absorb glucose from the blood. Muscle cells absorb glucose for energy. Liver cells absorb glucose and store it as glycogen. Fat cells absorb glucose and convert it to triglycerides for storage. Insulin is the key that unlocks the door on every cell, allowing glucose to enter. When insulin works properly, when cells respond to its signal efficiently, a small amount of insulin is sufficient to clear glucose from the blood after a meal. Fasting insulin levels in a healthy insulin-sensitive individual are typically 2 to 6 microunits per milliliter. Insulin resistance is the condition in which cells stop responding efficiently to insulin's signal. The receptors on cell surfaces, insulin receptors, become desensitized. The key still fits the lock, but the lock is stiff. It takes more force, more insulin, to open the door. The pancreas compensates by producing more insulin. If a healthy pancreas produces X units of insulin to clear a meal, an insulin-resistant pancreas must produce 3X, or 5X or 10X to achieve the same glucose clearance. And as long as the pancreas can produce enough insulin to compensate, blood glucose stays normal. The fasting glucose test comes back at 95. The A1C comes back at 5.4. The doctor says you're fine, but you are not fine. Your pancreas is working 5 times harder than it should. Your insulin level, the number nobody measured, is 22 instead of 5. You are insulin resistant. You are on the path to diabetes, and no one told you because no one looked. This compensation can continue for years, often 10 to 15 years, before the pancreas begins to fail. The beta cells that produce insulin are under enormous stress, producing quantities of insulin they were never designed to sustain. Over time, they burn out. Beta cell mass declines. Insulin production falls. And now, for the first time, blood glucose begins to rise, first into the prediabetic range, fasting glucose of 100 to 125, then into the diabetic range, above 126. The A1C crosses 5.7, then 6 points. Your doctor finally diagnoses you, but the disease didn't start when your glucose rose. The disease started a decade earlier, when your insulin level first began to climb. The glucose elevation is the end stage. The insulin elevation was the beginning. and we only test for the end stage. The analogy that captures this perfectly: imagine a dam holding back a reservoir. The water level behind the dam represents insulin resistance. It's been rising for years. The dam represents your pancreas, producing enough insulin to hold the water back, to keep the glucose from flooding into your bloodstream. Your doctor is standing downstream looking at the river and saying, "The water level looks normal. You're fine." But behind the dam, the pressure is enormous. The structure is straining. Cracks are forming. And when the dam finally breaks, when your pancreas can no longer compensate, the flood of glucose that your doctor finally measures was building for a decade while they checked the wrong side of the dam. The numbers are staggering. According to the CDC, 88 million American adults, more than 1 in 3, have prediabetes. Of those, 84% don't know they have it. They don't know because the standard tests their doctors order don't detect it in the early stages. Fasting glucose misses early insulin resistance because the pancreas compensates. A1C misses early insulin resistance because it reflects average glucose over 3 months, and compensated insulin resistance doesn't elevate average glucose. The test that would catch it, fasting insulin, is not part of the standard metabolic panel. It is not automatically ordered. It costs $15. It is available at every Quest, LabCorp, and hospital lab in the country. And it could identify the 88 million Americans heading toward diabetes years before they arrive. What should your insulin level be? There is no universally agreed upon normal range for fasting insulin, and this is part of the problem. Most laboratory reference ranges list normal fasting insulin as 2.6 to 24.9 micronits per milliliter, a range so wide that it is clinically useless. A fasting insulin of 24 is not normal. It indicates significant insulin resistance. Optimal fasting insulin, the level associated with insulin sensitivity, metabolic health, and low cardiovascular risk, is below 5 to 7 micronits per milliliter. Levels above 10 indicate emerging insulin resistance. Levels above 15 indicate established insulin resistance. Levels above 20 indicate severe insulin resistance, a pancreas working at maximum capacity to maintain glucose control. At these levels, the question is not whether you will develop diabetes. The question is when. The HOMA-IR calculation, homeostatic model assessment of insulin resistance, provides a more refined assessment. It combines fasting glucose and fasting insulin into a single number using the formula. Fasting insulin times fasting glucose, U405. A HOMA-IR below 1.0 indicates optimal insulin sensitivity. Between 1.0 and 1.9 indicates early insulin resistance. Between 2.0 and 2.9 indicates significant insulin resistance. Above 3.0 indicates severe insulin resistance. You are in the prediabetic zone regardless of what your fasting glucose says. Both numbers, fasting insulin and HOMA-IR, require only a standard blood draw. They cost next to nothing, and they provide 10 to 15 years of early warning that fasting glucose and A1C cannot. What is causing the insulin resistance? The mechanisms connect directly to everything we've discussed across this network. Chronic carbohydrate overload, a diet dominated by processed carbohydrates, forces the pancreas to produce large quantities of insulin after every meal, every snack, every sugar-sweetened beverage. Over time, the cells downregulate their insulin receptors. They become resistant to the constant barrage of insulin signal, just as your ears adjust to constant noise by becoming less sensitive to it. Seed oils, omega-6 linoleic acid integrates into cell membranes, altering the fluidity and function of insulin receptors, contributing to receptor desensitivity. Visceral fat, fat stored around organs, particularly the liver and pancreas, produces inflammatory cytokines that directly interfere with insulin signaling pathways. Gut-derived inflammation, LPS from a leaky gut, activates inflammatory pathways in the liver and adipose tissue that block insulin receptor function. Poor sleep, even one night of sleep deprivation reduces insulin sensitivity by 25 to 30%. chronic stress, cortisol directly opposes insulin's action, maintaining elevated blood glucose and forcing the pancreas to produce more insulin to compensate. What should you do? The action plan starts before your next doctor's appointment. Step 1. Request a fasting insulin test. Tell your doctor, I want a fasting insulin level, not just a fasting glucose. If your doctor resists, order it yourself through a direct-to-consumer lab service. It costs $15 to $30. Step 2. Calculate your HOMA-IR using the formula above. If it's above 1.9, you have insulin resistance regardless of your glucose or A1C results. Step 3. Begin addressing the root cause. The root cause is not blood sugar. The root cause is insulin. And the solution is not medication that lowers blood sugar while ignoring insulin. The solution is dietary and lifestyle changes that reduce insulin demand, restore insulin sensitivity, and allow the pancreas to recover. Let me close with a reframe that this entire channel will build upon. Diabetes is not a blood sugar disease. It is an insulin disease. Blood sugar is the symptom, the last domino to fall after a decade of escalating insulin resistance. By the time blood sugar rises, the damage is done to the blood vessels, to the liver, to the kidneys, to the nerves, to the eyes. If we wait for blood sugar to diagnose the problem, we are waiting until the house is on fire to notice the smoke. The insulin level is the smoke detector. It catches the fire early, years early, when the damage can still be reversed. The test exists. It costs $15. Your doctor probably didn't order it. Now you know to ask. In the next video, I'm going to explain the exact test that can predict your diabetes diagnosis a decade before it happens. A test developed by a pathologist who spent 25 years and 14,000 patients proving that insulin, not glucose, is the key to early detection. Most doctors have never heard of it. After this video, you'll know more about it than they do. I'll see you there.